Hi everyone, this is Chitra working as a NICU staff nurse in Dr. Mehta Hospital. Today I am going to do an informative video for those who are working in NICU. It is a rare and important treatment procedure that all should know, that is cooling therapy. Before going to cooling therapy treatment, first we should know what diagnosis need cooling therapy treatment, that is hypoxic-ischaemic encephalopathy. What is hypoxic-ischaemic encephalopathy? Is a lack of sufficient oxygen in the brain and a diminished amount of blood perfusion to the brain. This results in suppression of electrical activity and cortical depression. Let us see what is therapeutic hypothermia. Therapeutic hypothermia is also known as hypothermia therapy, brain cooling, cooling therapy, and cooling treatment. Is a procedure used to help slow down the injury process associated with the HIE. Criteria for cooling therapy. The baby should be at least 35 weeks of gestational age and more than 1.8 kg, less than 6 hours of post-birth. Evidence of asphyxia as defined by the presence of at least two of the following in 4 criteria. ABGA score less than 5 at 10 minutes or continued need for resuscitation with PPV with or without chest compression at 10 minutes of age. Any acute perinatal event that may result in HIE, that is abruptio placenta, cord prolapse, severe fetal heart rate abnormality. Cord pH less than 7 or base deficit of 12 or more within 60 minutes of birth. If cord pH is not available, arterial pH less than 7 or base excess more than 12 mmol within 60 minutes of birth. Why we are strictly focused caring cooling therapy in HIE babies. This picture depicts hypoxic-ischemic encephalopathy pathophysiology. When primary hypoxic insult occurs, there will be lack of oxygen supply to the baby to the brain. Lack of oxygen supply to the baby will lead to ischemia, that will be further lead to neuronal death and affect brain damage. Next, let us see what are the phases present in cooling therapy and how to induce therapeutic hypothermia. The aim of cooling therapy is to achieve the target temperature within 1 hour of commencement. The normal rectal temperature is 33 degrees Celsius to 34 degrees Celsius. The total period of cooling and rewarming is for 84 hours, consists of 2 phases. First one is active phase, second one is rewarming phase. Active cooling for 72 hours from the initiation of cooling. Second phase is rewarming. 12 hours of active gradual rewarming time after completion of 72 hours of cooling. Increase temperature by 0.5 degrees Celsius every 2 hours as documented in the EMR or medical records. Monitor temperature frequently following rewarming to prevent rebound hypothermia. This slide shows equipments needed for the application of cooling therapy. Meditherm 3, Tecotherm or Miracradle as per unit policy. Rectal temperature probe. Nurse the infant naked on a radiant warmer with the warmer switched off. Do not nurse in an incubator. Next is type of cooling. This picture shows two types of cooling, whole body cooling and head cooling. Moving on to the important part, nursing assessment and management. Monitor the baby continuously. It should be include all vital parameters, ECG, BP, saturation and heart rate. If the baby affected systematically, that baby usually require ventilatory support or other mode of respiratory support to maintain adequate oxygenation and ventilation. If the baby require any mode of respiratory support, use humidified heated gases. Heart rate maintaining 80 to 100 beats per minute is normal. If any abnormalities, change the temperature accordingly. Continuously monitor the BP. Watch for any arrhythmias. Next is temperature monitoring. Temperature monitoring need to be continuous throughout the treatment. Insert a rectal probe 5 cm into the anus in order to get accurate temperature. The rectal temperature should be at the range of 33.5 degrees Celsius to 34.5 degrees Celsius. Check the rectal probe hourly. Monitor the skin temperature regularly in order to prevent hypo or hypothermia. While observing neurological status, commence amplitude integrated EEG monitoring. 80% of newborn will occur seizure within the first 24 to 48 hours. So, while occurring seizure, follow the seizure management of algorithm. Check pupils, evaluate level of consciousness and for signs of raised intracranial pressure. Will need formal EEG and MRI after 3 to 7 days of rewarming. While doing blood sampling, it is easier to get sample from UAC, so central catheterization done prior to starting cooling therapy. Normally, blood samples are taken on admission prior to start cooling therapy. Then 4 hours, 8 hours, 12 hours, 24 hours and 72 hours of life. Infant with the HIE are at risk of multiple electrolyte imbalances, so need frequent monitoring and correction based on laboratory levels. Coagulopathy values, sodium levels, magnesium levels are also important to check. While monitoring fluid balances, most infants are fluid restricted to avoid fluid overload and cerebral edema. Total fluid intake is usually 40 to 60 ml per kg per day. Commencing enteral feeds in infants during therapeutic hypothermia should be considered on an individualized basis, taking into account the overall clinical status. Site for urinary catheter. Strict fluid balance is required. Sedation. Infants may require low dose of morphine or fentanyl infusion as per institution policy to optimize comfort and efficacy of the cooling process. Monitor comfort using modified pain assessment tool. Inadequate sedation can result in increased metabolic rate, which decreases the effectiveness of cooling therapy. At 48 hours of life, the weaning of morphine or fentanyl should be considered. Inadequate sedation leads to increased heart rate, shivering, and difficulty ventilating. Focusing on main part of infection control, hypothermia can cause immune dysfunction. So, cooled infants are often covered prophylactically with IV antibiotics. Strict infection control practices should follow. Daily review for evidence of infection. Focusing on skin care, need frequent inspection of skin and repositioning of baby. Infants can be nursed supine and 30-degree tilt to right or left to avoid impairment to cerebral blood flow return. Monitor skin for color, perfusion, skin breakdown and for signs of subcutaneous fat necrosis. This slide shows what are the effects of cooling therapy. First one, cardiovascular complication, bradycardia, prolonged QT interval, ventricular arrhythmia, reduced cardiac output and hypotension. Reduction in surfactant production, increased pulmonary vascular resistance, increased oxygen consumption and oxygen requirement. Electrolyte imbalances like hypokalemia, hypomagnesemia, hypophosphatemia. Coagulopathy abnormalities, mainly platelet dysfunction. Infection risk increases due to inhibition of pro-inflammatory responses. Pharmacokinetics alter due to change in liver and renal function, delayed gastric emptying and elevated serum amylases. Consider nutritional plan and the need for parenteral nutrition. This is about concised cooling therapy. Hope you all understand. Thank you.